Okay, all right.
Martin Van, I guess Fauja. Good morning and welcome. Welcome to our November board meeting. And as usual, I'd like to welcome members of the public and of the press who are accessing the meeting virtually today. And welcome Kate Patience-Quate to our meeting in her capacity as interim nurse director. Also like to notify you that the meeting is being recorded for future upload to our web, and to remind board members and participants to use the show hands facility rather than the chat function. With that, over to Ruth for any apologies.
Thank you, Boyd. Yeah, so for today's meeting, we have an apology from Brian Williams from UHI. I'm aware also that Susan Ringwood is having some technical difficulties in accessing, so she'll be arriving as soon as she possibly can. And we're aware also that Alex and Philip will also need to leave at some point during the morning session. So thank you.
And Graham has also indicated that his connection might not be entirely secure during the whole meeting. Declarations of conflicts of interest. Any declarations? Alistair.
Yes, thank you, Boyd, and good morning, colleagues. I had considered making a declaration of interest in my capacity as a Highland councillor. However, having applied the objective test and looking at my personal connection in relation to the items on the agenda and any connection thereon, I do not believe I need to do so. Thank you.
Thanks, Alistair. Any further declarations? If not, we can move on to item 3, the minute of the meeting of 27th September and the attendant action plan. Can I ask if there are any amendments, corrections to be made to the minutes? Pages 1 and 2, 3 and 4, 5 and 6, 7 and 8, 9, 10, and a short 11. Are there any amendments required? See any hands? So can I take it that we approve the minutes of that meeting? Thank you. And that we also note the action plan. Ruth, are there any items you'd want to draw to our attention?
Thank you, Boyd. No, other than the fact that the update in relation to the National Treatment Centre, which was previously scheduled for September, is on this particular agenda. So you'll see that at item 10 on today's agenda.
Thank you. With that, can I ask if there are any matters arising from the minutes that anybody wishes to raise at this juncture? Don't see any hands, so move on to Chief Executive's report and an update on emerging issues, which there might be one or two. Pam?
Good morning, thank you very much, Chair. I suppose there's actually quite a lot on our agenda today that are the ongoing areas of focus for us. So we will probably talk quite a lot about our ongoing challenges, but also opportunities as the meeting goes on. But I suppose the two areas I want to just highlight and draw some attention to are obviously the pressures in the system and also our vaccination programme. So I'll start with the pressures in the system, and obviously you're going to hear later about our winter readiness plan, and we'll get some of the detail of that. But just to remind us of the situation that we are working in, which is one of a very pressured system, but a system that every day is delivering really good care to many people. And we still have quite a number of compliments coming into the system directly to myself and into feedback about the excellent care that people are experiencing right across our system. And I think we need to not lose sight of that, because often in our day-to-day business, we're very focused on the bits that are more challenging, and sometimes you can lose perspective on the vast majority of our services that are working well and people are getting good service from. But that aside, we continue to be challenged, and the circumstances of balancing dealing with emergency and unscheduled care versus more planned approaches to the health and care that we deliver right across the system. Obviously, central to that is, how we deal with our waiting lists, both in outpatients and as we operate. And a big determinant there is the balance between what can be done in day surgery and what can be done where a bed is required for recuperation. And that balance between the beds we require for emergency admissions versus being able to continue with our elective programme is a daily challenge for our staff as they try to balance that. I think at the centre of that, again, just to remember that the constraints of staffing and the constraints of finance are always there, but the dominant, I suppose, feature in terms of trying to make this work is about how we can recruit and retain people within our workforce and be able to deliver the best service we can within the resources available to us, and that is indeed what we're trying to do. I think a couple of things that I think are important to highlight in this. So the first one is about self-care. What can the public do to help us? So two of the big reasons you might find yourself in hospital or struggling in the community in the winter is as a result of respiratory conditions and as a result of falls. And so there are good self-management advice and tools and resources available to help people prepare for that. And again, alongside the national campaigns, we're looking at how we can up the availability of that information and get those messages out to communities and individuals as to how they can care for themselves and prepare for those circumstances so that they prevent themselves finding themselves in that really difficult and challenging situation of being admitted to hospital and unable to function. So we will be pushing forward with some of the key messages and targeted approaches across our communities to try and support people being equipped to understand how they can do good self-care and prevent some of these things from happening. And both of those items are preventable. I think the other part I want to make you aware of in particular, we know the challenges of social care, we know the challenges of care at home services, and our team in adult social care have come up with a kind of concept of making a plea out to communities to get reservists. So they're looking for, obviously, to recruit permanently to posts that they have, but they're also looking for an agile workforce where people who really enjoy supporting members in their community and could do something towards the efforts of care at home and indeed supporting care homes. And so they are looking to try and get a reservist movement, if you like, or workforce mobilised that can be very agile and very flexible. And the key thing they're looking for is for people who enjoy that type of work, and if any training is required, they will supply it. So maybe something that we can all take out into the communities, and perhaps the message from here can be heard beyond this meeting. But a really good initiative framed well, and hopefully that will, mobilise and encourage people to be part of helping us get through this winter and keeping, most importantly, our population across NHS Highland and indeed Argyll and Bute safe. So that's what I wanted to say about the pressures, but obviously we'll talk more about that. I think the other aspect then is just to say a bit about our vaccination programme. We have been working full pelt around this, and whilst there has been a lot of learning in, again, this next level of vaccination that we have had to take responsibility for as a board, we have had good uptake. We are delivering the programme, and I think it's again really important to emphasise, we are delivering this programme over 146 sites. There is nowhere else that is dealing with that level of a geography, if you like. So that does make us different. And on a number of our islands, the GPs have been partners in that, where that's been possible to do within the national policy and the GP contract. But in all those other sites, we have had to mobilise both core teams and, again, a workforce who will participate in this. So it's no mean feat. 146 sites to deliver, and I know that whilst we've used the national system, that has caused some distress for some people. On the whole, this has been a successful programme, and we'll continue to work nationally with the team there and locally to refine and improve on that. But just some headlines in terms of the COVID uptake. Our care home residents, 93% uptake against the Scotland average of 89%. So we've done very well there. Frontline staff, 44% against the Scottish average of 40%. And people over 65, 82, slightly behind the Scottish average of 87%. So we continue to focus strongly on this and take it forward, but I think it would be wrong to say that this hasn't had a lot of success amidst a lot of learning, and that's probably where I want to leave it today. Lloyd, thank you.
Thank you, Pam. Are there any questions for Pam on these matters that she's raised, or anything else? Bert.
Yes, thank you, Chair. Thank you, Pam, for that input. A lot of work been done in relation to the vaccinations. That's very pleasing and indeed reassuring. I wanted to ask if you could tell us a little bit more about the reservists. I think this is a really worthwhile initiative. What I didn't catch in your input was the range of locations that the reservists might be used in. I wonder if you could just remind me of that, please.
Yeah, so this is really just kicked off as a new thing to try out, if you like, in terms of trying to mobilise the workforce. So last year, we did go out with a plea for the care home, for the COVID response team, and which then became the care response team, and that did mobilise a workforce that we hadn't had before. But we're trying to be even more flexible this year in this idea that our frontline staff have come up with and are pursuing. So we've started first in Inverness. It's still very early doors, but they will be looking to connect out into our further remote communities. So I'll be able to bring more information about that as we go through this month and see what the uptake is. The early indicators of the event that they did in Inverness were positive, but it is a very new and live initiative. But I felt it was really important to share that with you, that initiative has started, and I think it does have an appeal that we hope will have an impact.
Thanks, Pam, and I appreciate getting that sharing of news. Just one thing that occurs to me: is there any implication in terms of PVG requirements?
I mean, everything will be done. It still has to be done through a formal process. Fiona might be able to advise on the timescales around that at the moment, but I don't think there's any particular issues with PVG at the moment. But Fiona Hogg is on the call and might be able to just confirm that.
Yeah, that's right. So effectively, they would be treated, kind of like our bank workforce or others. So we've got processes in place. They would have to have all the sort of referencing and PVG checks done, but there's no major holdups in the system at the moment, and that'll all be part of the project plan.
Okay, thank you very much indeed. Thank you.
Thanks, Bert. Any further questions or points for Pam? I think it's a very enterprising and novel initiative on the reservists, and I hope it bears some fruit. Muriel.
Thank you, and I think it's a very exciting and forward-looking initiative. One thing, Bert mentioned the PVG. Would there be access and support for training? I'm thinking along the lines of our manual handling and all the other things that NHS are very good at providing.
Yes, absolutely.
Okay, any further comments or points? If not, can we move on then to the next item, which is the Integrated Performance and Quality Report brought to you by the dynamic duo, Lorraine and David. I think, David, are you going to lead off and orchestrate this one?
Yes, happy to. Teams has just given me one or two issues this morning, so hopefully I'll be able to see the hands, although I can't see the list of people, so I might get the order wrong. So if you bear with us, we'll have the opportunity to work through that. Yeah, so you've colleagues have got the copy of the IPQR report coming to the board here. Today, we obviously have circulated the information, and that has gone through the Finance, Performance and Resources Committee, Clinical Governance, Staff Governance, as well as through the relevant sections anyway through HSCPs. So it's coming to the board having been scrutinised in those areas. Pam's already given an update on vaccinations. That's the information is also available in the report, albeit some may receive more updated information since this was published. There's some more information around Startwell. You'll see there's some additional charts in there. They will be periodically updated. I think they're reported, some of them only twice a year. We have to do that nationally, and they're included in the report for this month. Also, you'll see the results of our systems pressures both across our scheduled care as well as unscheduled care. Just to draw attention to our ED performance, although it is below what we would aspire to, the teams are performing remarkably well given the level of systems pressures, which compares favourably to the performance across the rest of the country. But nonetheless, as I say, our aspiration is that would be higher. One update that I would like to give you at the start is around cancer services, which is obviously services that are very important to us. And I'm going to invite Catherine just to say a few words on that, because we've got some better information and more up-to-date information, which I think would be relevant for the conversation today, after which we'll open it up to questions. So Catherine, if I can invite you.
Hello, thank you, David. Yes, and you can see that from the period that this report relates to, there was a dip in performance in terms of the cancer target that we would be aiming to deliver. The main reason behind that relates to a capacity gap that we had within our breast service around both the diagnostic elements of breast service, the radiology elements, the pathology elements, and also indeed in terms of surgeon capacity to deliver. And what that did then was build up a delay in terms of the capacity that we had to take patients through the system. So there has been a response to that over recent months, and I'm pleased to confirm that our performance has recovered more recently. Our performance for September on the 62 days target is 73.5% compared to the Scottish average of 72.1%, and the 31-day standard is 85.3% compared to a Scottish average of 93.6%. Our October performance has on the 62-day standard is 70%, and for the 31-day standard has recovered to 94.4%. As I say, the diagnostic elements in particular have been impacting along these pathways, and a lot of work has been ongoing with the teams, understanding how to build capacity into the system. So happy to take any questions at all on that, David, that may be required.
Thanks, Catherine. Alistair.
Yes, just thank you, David, and thank you, Catherine. I think that's really useful to get a more timely update as to where we are. What do we need to do as a health board to ensure that we sustain this improvement and build on it further? Because in the past we've had this where we've made an improvement and then for various factors, usually around staffing or availability or recruitment, we've lost it. So what was we as a board could do to actually make sure that we can actually sustain and maintain and improve further these numbers? But they are really good. Thank you.
Thanks, Alistair. If I just come back on that, the biggest issue obviously is resilience in the system and workforce to deliver, and a lot of the cancer services, when we get into specialist service, require really key individuals that have very specialist roles within the cancer pathways. And in Highland, obviously, though there are resilience issues, we are taking a different approach now to our cancer performance board, and that is being refreshed, and it very much will be focusing on the strategic elements and looking at networking beyond Highland and across Scotland to ensure that we can foresee these things happening and work with colleagues as much as we can to avoid getting into these situations. But it is a dynamic situation, Alistair, and I'm sure you can understand. I'm not making excuses here, because we need to plan ahead and we need to think ahead as much as possible. But the capacity for some of these things, particularly around pathology, for example, are significantly limited across Scotland and indeed across the UK nationally. So some of the solutions to this has come through working differently, and that takes some time to actually take those things forward, using technology to support us delivering services around the pathology pathways, and that certainly is helping us to become more resilient. So I think it's about us understanding, thinking ahead, and being more proactive and on the front foot in terms of redesigning before things have fallen over to the extent that they have done in the past. So there is learning definitely there for us that we're taking forward. Thank you.
Thanks, Catherine. I'm not sure between Alex and Jenny who was first, but Alex, I'll come to you.
Thanks, David. I think it was, it was a full finish. Quick question on outpatients, and not so much what we're doing now, because clearly that's the number we're seeing there in August. It's the line underneath, the bit in italics about the new outpatient list is increasing rapidly and monthly activity is not able to meet demand. Is that because we've had to cut back on what we're doing outpatient-wise? Because if I remember rightly, we had a discussion about funding and how much funding we were getting for outpatients. And can we improve it? Have we met the less than 18-month target for December, or are we close? Because I noticed we literally just missed the 2-year one, which is a shame, but that's what it is. But what are we doing in terms of funding? Because clearly we've got financial pressures coming. Well, they're here now. But what impact is that having? And then, as it says there, if we don't get the outpatients bit under control, it's going to have a knock-on with TTG numbers as well. And therefore, that's another target that we haven't got a hope in hell of hitting. Thanks.
Thanks, Alex. And Jerry, maybe I can come to you and just take your question, and then we can maybe direct them accordingly.
Thank you very much, David. I mean, I've got a couple of questions on a couple of distinct areas. probably using CAMS and drug and alcohol as the services. I just wondered how we were approaching the issue of long waits and whether we had a different strategy for addressing long waits as opposed to getting your, if I use the term business as usual, back into seeing people, the new referrals as quickly as possible, which possibly ties in with Alex's question on outpatients. And my second question related to ED, and I don't know if I just noticed it this month or it had been added on, the ED attendances by flow group. And I noticed that we're probably up about 65, 66% of our attendances are flow group 1. And I just wondered, following on from Pam's opening remarks, is it too simplistic to suggest that those 4,100 attenders in that period are attenders who could possibly have went to an alternative source for treatment, but they chose to come for ED for some reason, given it's categorised as minor injury? But I appreciate that minor injury is a vast definitional term. So those are my couple of points, David. Thank you.
Thanks, Jerry. So, Catherine, if I can come to you for both the outpatients part and the ED element, and then Louise, I'll come to you for CAMS and drug and alcohol services, and then maybe Fiona Davis. I don't know if you have anything to add from an Energetic Impute perspective on the latter two in particular. So, Catherine.
Yeah, so thanks, Alex, for the question. On the 2-year target, just to share that particular target, there was, I think, 2 patients that missed that target, and they wanted to reorganise their appointments. So just to be clear as to the reasons for that, they were offered appointments, and I think that's important. How are we doing on the end of December target? We've made significant inroads, and we have reduced by over 800 patients from where we were when we started out to deliver that target. We continue to be working hard in that space. Gynecology and ENT are our current challenges, but the numbers are very, very small, and we work to continue to minimise that. The target comes in to the end of December, just to be clear on that. The Scottish Government funding has been reduced, and we, as a result, will be challenged to meet the target that then is expected of us for the end of March next year. And we're looking at how we can think creatively. How do we deploy the efficiency improvements that we know we need to put into the various services to help us with that? We are working with the Centre for Sustainable Delivery and the national team to look at redesigning workforce so that we can deliver a more resilient workforce and delivery going forward across all outpatient areas, and also to take advantage of redesign opportunities and patient pathway opportunities, including the use of technology on the outpatients front. So I hope that answers your question, Alex, but just before I move on to the emergency department, can I just sense check that with you?
Yeah, the funding issue, Catherine, I take it that's still under discussion, or maybe Pam can answer it. Is that now fact? We're not getting that money.
So that is pretty much fact. There is no more funding as far as I'm aware, and certainly no discussion. All the discussions I've been involved with, Scottish Government, they are expecting that we will not be able to deliver the plan that we had originally agreed with them, and we have gone back and had those conversations with them. It's a dynamic position because we want to do the best we can for the patients of the Highlands, so we're trying to be as creative as possible in terms of how we actually approach that, how we secure capacity for that, and some of that is around us working with partner boards and other boards in Scotland to help us deliver additional capacity, and also looking at delivering, as I say, using virtual appointments. As you know, we can deliver through Near Me, so sometimes we can access capacity that isn't local to Highland that helps us to deliver appointments for patients. So we're doing all that we can in that space to deliver. I think you'd asked as well about, will that, if we keep going at the outpatient side of things, is that going to impact on the TTG and the number that are waiting to get through on TTG? It will push more patients through the system, but it is the right thing to do to continue to deliver, because patients that haven't been seen, haven't been assessed in terms of need, when they're in our system, we understand the relative importance and we understand how we can wrap around these patients and support them whilst they're waiting as well, and they're known to us. So I think that's very, very important that we do continue to push on that front. So Jerry, in terms of the CAMS question, if I could come to that one first of all, we are working, we have been doing delivering additional capacity, a waiting list type approach for the children on the waiting list that have been waiting longest, with a view to accelerating the reduction in the longest waiting patients to access the CAMS service. We're also looking at working differently, so we're developing capacity through delivering through different roles. Again, nurses delivering some of the interventions and building capacity through that route, as well as working to attract more colleagues to come and work with us in the Highlands. We have new leadership in place as well, and the leadership is working with the teams and indeed our adult psychology capacity to examine what can be done to deliver as much as we can with the resources that we've got. And we are driving forward with a recruitment campaign as well to up the workforce that we have for our Highland, to deliver to our Highland capacity. So hopefully that answers on the CAMS front, but Jerry, if I could just check in with you before I move on to the ED question.
Yeah, you can move on, Catherine.
Yeah,
that's fine.
great.
Thank you, Catherine.
Okay, thank you. I couldn't see you on my screen. There's so many people on it. Thank you. So, yeah, the emergency department, the flow group 1 is minor injuries. And we are looking at, how can we build capacity? Certainly, we have put in a dedicated workforce to deliver to minor injuries. And we're also looking at redirection wherever we can, away from the emergency department, and working with the public through public messaging as well, to reduce the number that go through the minor injuries group as much as we possibly can. We're also looking at the potential for scheduling access to minor injury capacity and working with the public, particularly for us in Highland, as we have a fair number of minor injuries units that are sort of strategically positioned around the Highlands. So it's good for local people to be able to take access through those routes. We are limited, we can't do everything everywhere, and quite often minor injuries require X-ray, so we do have to direct people to the right facilities so that their pathways can be as efficient as possible as well. Again, Jerry, just sense check with you that answers your question.
No, it does indeed. Thank you very much, Catherine.
Thanks, Catherine. I know Louise had to dip out just for a moment. Fiona Davies, can I come to you to talk to the update from our Highland Board around those items?
Yes, certainly, David. Good morning, everybody. I wonder if it's also just in addition to that to mention that I've now taken on the exec lead for the urgent and unscheduled care programme across the board. So many of the initiatives that Catherine is describing have an impact in Argyll, but I've been supporting that programme in looking at those right across the board area. And maybe just one other that I would reference to Catherine's very comprehensive answer is that we're looking at the way that the Flow Navigation Centre has been implemented in and across Highland. It is one of the anchor points, as the government call them, with the urgent and unscheduled care programme of work through the collaborative. And there's probably more that we can do to extend the role and function of the Flow Navigation Centre, which is probably a key intervention to offering some of that potential alternatives to the Flow Group 1 patients, as well as potentially offering support to neighbouring and smaller boards. So I think that's an exciting area of work that we'll continue to update the board on as it progresses. So looking at it now from an Argyll and Bute lens more in particular, I suppose one of the other initiatives that I would also mention is that Argyll and Bute, amongst I think some other areas of Highland, have been successful at making a bid to the hospital at home scheme being rolled out by the government, which is about looking at transferring particular clinical interventions that have been undertaken traditionally in hospital and putting those into community delivery. So again, we're at the very early stages of understanding the impact that that's going to have on our performance in the hospital, but I think it's a very welcome initiative as we think about shifting the balance of care from acute services into community services, as has been the strategic intention for so many years, but often is very difficult to deliver, but very tempting to talk about. So that's very welcome. We've seen good performance in Oban Lawn and the Islands around our emergency department. I just had a quick look while Catherine was talking, so thanks, Catherine. And our rolling 7-day performance figure sitting at 97% in terms of our ED performance, which is great. So yeah, we're seeing that holding up despite the challenges, as Pam referenced, around care at home. We have similar challenges in Argyll and Bute, so but that hasn't yet seemed to cause an impact on our ED figure. Just picking up the CAMS issue, if I may, similar to Catherine, we've been targeting our waiting list with some specific initiatives in reducing our longest waiters that you were asking about, whether we've done something specific. I don't have the latest figures just at my fingertips, but the data I have got available, we saw a 40% reduction in our longest waiters between Q1 and Q2 this year, as well as an overall reduction in our waiting time for CAMS. So I think that's probably an indication that we're heading in the right direction, but as Catherine said, there's more work to do. So I hope that's a helpful update.
Thanks, Fiona. And finally, we've come to Louise with regards to drug and alcohol services. Thanks.
Many thanks. And just to add to what Fiona was saying around hospital at home, there's 2 areas within North Highland that have been identified for exploring that model too, which is on Skye and Caithness. So I think one of the important things is going to be how the different areas learn from each other and develop what we're doing as we move forward with that important piece of work. And certainly the team in Skye have been to meet with the Western Isles team who were taking this on during COVID. So I think there's a lot of positive benchmarking we can do around the hospital at home element. And in relation to the drug and alcohol, one of our biggest challenges, as with every area, as Pam referenced at the beginning, is our recruitment, and we do really struggle in some areas in particular. However, we have had some positive recruitment recently within some of our more difficult to recruit areas like Caithness, which has been really good news. And you'll see from the information that actually has been some good work done on reducing those ongoing waits and getting people through more quickly. And that has been the team really focusing down on, similar to the work that the CAMS have been looking at in terms of getting people in the door as quickly as possible. And it may be that they don't need a huge amount of intervention and they can be moved on quickly, or we may have to do more with them. But they're really trying to look at that front end and how we see people rapidly and see if we can either signpost or take them into the services. So that work is going quite well, as you'll see from the information. Our challenge is A, sustaining it, and B, getting the staff in. So a lot of what we're looking at is also how we recruit and how we work with the third sector, because we have had new monies around drug and alcohol services, and we're looking at how we can use our partners within it.
Thanks, Louise. And obviously for drug and alcohol services, the new MAC standards are applying to all of our areas for both the Highland region as well as Argyll and Bute, and that's what the teams are focused on in terms of implementing and delivering. If I can come to Anne Clark, thanks for being patient.
Morning, colleagues. Just a couple of things, a specific question, and then to pick up on Alex's points, a broader question. I was interested in the CAMS information about the improvement activities and the discussions about integrated working, and I wondered if I could ask whether we are fully involving our third sector colleagues in those various discussions, for example, in the revised programme board and elsewhere. I think that there's been some significant investment come through the third sector recently, and it seems really important that we're fully taking advantage of that. Then more broadly, I wondered if I could sort of extend the discussion in response to Alex's point about outpatients. Clearly, none of us would want to be having to discuss trade-offs between performance and finance, but we are going to come on to discuss a very challenging financial picture. So I wondered if moving on from outpatients to other areas such as electives, where we have also seen a reduction in our expected allocations, is our general approach to reduce our activity in line with these reduced allocations? And is Scottish Government responding positively to our revised plans, or are there areas where we're not in a position to take that approach? Thanks.
Yeah, thanks. And good questions. On the CAMS question, first of all, can I come to Fiona Davis first, and then I'll come to Louise on that, and then we'll look at the TTG question you've asked.
Thanks, David, and thanks, Anne, for that excellent question. In Argyll and Bute, as you know, children's services are fully delegated to the IJB. And we also, in addition to having our own, obviously, internal processes, have a children's strategic group that sits within the Community Planning Partnership. I'm the chair of that group, and that group has partners from across education, health and social work, as we would have said once in the day before we were integrated. And also we have very good representation from the third sector in that group. And that's an opportunity for us to ensure that we're maximising the opportunities for the third sector to come and work alongside other statutory partners in the delivery of interventions and outcomes for children in the Argyll and Bute area. So I think that probably offers quite significant assurance that those conversations are forthcoming. I was recently fortunate to attend a conference that was organised through that strategic partnership for trauma-informed practice, at which the third sector were incredibly well represented. And demonstrated the range of partners from the third sector that support delivery of outcomes for children and families in Argyll and Bute. So yes, I think it's something we can always work more on. Obviously, we have capacity challenges in the third sector in rural areas, and that's a broader issue that we're taking up with our third sector interface chief executive. But another thing I would also just reference is that our third sector interface chief executive has recently taken up the role of the chair of the corporate parenting board in Argyll and Bute. So I think you can see kind of through all these examples of how closely what the statutory sector and the third sector are working together to improve outcomes for children in Argyll and Bute. Thanks.
Thanks, Fiona. That's really positive news in terms of that progress. Catherine, do you want to add anything from a Highland perspective on that part before we come to the second question?
Absolutely. So our new head of ops for Women's and Children's Services has re-established and reformed the CAMS programme board for Highland, and that includes colleagues and services across Argyll and Bute. It's very much focused around the integrated children's services plan, and also is looking at the commitments that we've made through our ADP to in terms of deliverables deliverables and looking very much at improving outcomes for children through that programme board. So a variety of partners are assembled around that strategic work, and that certainly does include the third sector as well as a multitude of other colleagues that are also involved and partners that are involved in delivering services to children with a view to us if I use, making things less technical in terms of our response to them, and earlier, very much working around the early intervention agenda as well, supporting children and indeed families and carers around that, so that we can avoid as many children getting into crisis as we might have seen over recent years. Hopefully that answers your question, and thanks.
Thanks, Catherine. Now the question Anne, you've asked around TGG is very relevant. I think colleagues will recall that at the start of the year, the steer from government was very much around recovery of our waiting times and treatment times, and the commitments that have been given around it. We were given instruction to proceed with the activity based on assumed funding. And indeed, we made and have made in the past several commitments associated with that, including staffing of a permanent nature, not just a temporary nature. And so much of our financial commitment around this has somewhat been made. And then obviously the funding for treatment has not materialised to what was first indicated to us. So it is leaving us in a compromised situation, and we are having to make decisions around what activity that we that we will take up, and some of those are optional that we've still got decisions to make around. But I wonder, Catherine, if you wanted to give a little more detail or colour around exactly how we're going about that. Thanks.
Yeah, very much so, David. So we are having to revisit what we can deliver in terms of the funding that we've accepted. We had a plan, and we hope to run certainly a lot more additional activity than we are going to be able to deliver with the funding that we've accepted. As David has said, we were urged by Scottish Government to recruit permanently, and that was a good thing to do, because putting in a sustainable workforce that's here for the future to deliver means that we can deliver in a more cost-efficient way than bringing in the private sector partners that we've worked with in the past. Disappointingly, that the follow-through on all of that has not been there, and the commitment to ongoing funding is not there. So we are now running through a programme of work that is looking across all services again in terms of their waiting list, their performance. As I've mentioned earlier in the meeting, working through the Centre for Sustainable Delivery, ensuring that we have really efficient working practices in place so that we can see as many people as possible with the resources that we have available to us. We are also looking at, obviously, how we get best value for the limited funding that we've got, and looking at the activity levels that we are delivering through the capacity that we've got across the various services. There will need to be a degree of prioritisation. Some areas across Highland are delivering at a more rapid rate than other areas, so we need to ensure that we balance that as much as we possibly can do across our geographical area. And also in terms of access to theatre, we need to balance that across the clinical specialties and according to clinical needs. So obviously emergency, urgent and urgent suspected cancer has to be prioritised, and we're very much working with our clinicians to ensure that that is the route that we take. And obviously then applying the longest waiting time standards and ensuring that we can balance that as much as possible. You'll see from the integrated performance report that you have there in front of you, that orthopaedics continues to be our biggest challenge in Highland, and we are very much looking forward to the National Treatment Centre coming online, opening up next year. But even with that capacity that we will be delivering, we will still be challenged in terms of the rate at which we reduce the waiting list in orthopaedics. So again, we're working with Scottish Government colleagues very closely, and indeed across Scotland, utilising some capacity through the Golden Jubilee Hospital, and also looking at working with our partners in Grampian and in the north of Scotland to build capacity and to work differently going forward to deliver as much service as we possibly can with the limited resources that we have available to us. Thanks, David.
Thanks. And does that address your question? Or is there anything else you wanted to add?
Well, I think it was, yes, that's fine. I mean, I think it's just important that that we all hear and understand the very difficult, as Pam said, I think it was balancing acts that are going on at the moment. But also, I think it was useful to hear about some of the commitments that have been made, because clearly that is going to be an issue, presumably running on into next year, potentially. So I think it was just important to hear a little bit more detail about the, I assume, constant juggling processes that are going on within the system to try and deal with this, but also to understand that we don't have the ability to dial back in some areas because the commitments were made earlier in the year and expectations that didn't come to fruition. So that's, I think, important background for us to have. Thanks very much.
Thanks. And I think that tension, as you've described, it shows through the levels of frustration at times with our clinical colleagues who are trying to progress the recovery as fast as they can. And in some cases like this, we have to then take a different look at it and say, okay, if we don't have the resources we've got, how do we make sure that we use and utilise every piece of capacity that we currently have, that we can deliver the best care we possibly can. And so it puts us into that rethinking mode. So hopefully the frustration turns into ingenuity and creativity in terms of how that we can create. But undoubtedly there is a financial burden that's already been committed, and that will carry forward. Pam, you wanted to come in? Yeah,
and I think actually between Catherine, Anne and David, you've probably pulled out the key points. That trade-off, as you say, balance and act will continue for some time. And I probably just want to kind of emphasise that that's not just in the area of elective. That's right across our system. The choices that have to be made in terms of what can be done safely and well with the resources we've got, not just money, people. And I think the government in discussions recognise that. I think the challenge for us as a leadership team is to be able to credibly justify where we're at any given time, I guess, performance against money, against quality. And that's indeed with all the systems and processes that we've refined and put in place from our strategy through to our performance framework are really the backdrop to being able to be confident in that space, and through this IPQR show that we do understand, albeit difficult, where we're at. I think in my kind of thing this week is the last few weeks has been, we can't solve wicked problems because this is a complex wicked problem with a straightforward technical solution. Sometimes we have conversations that consider that we might just be, do an A plus B and it'll all be fine. This is not the world that we're in. It's much more complex than that. So that kind of narrative that David's spoken to there about reform, innovation and challenging ourselves is right at the heart of where we're at just now, because to get sustainable services, we do have to think differently, and that's not easy amidst a very pressured system, but that is the job and I think we are taking that extremely seriously and trying to support our teams to work through that. And some will take to that very easily, others will find that difficult, and we just need to be mindful it's a human system. Our business is all about people. The biggest resource we've got is all about people, and we have got to try and somehow guide and support them through that.
Thanks, Pam. I think that concludes all the questions and comments. Thank you for those. They're very helpful. I think that's been a helpful discussion. Chair, the SBAR that accompanies the report is suggesting limited assurance. I would say that's not because of the governance processes and that we have in place to look and review performance, but more the challenging circumstances and being able to deliver against our previous assigned ADP. So if I can hand back to you, Chair, that'd be fine. Thank you.
Thank you, David. And before leaving the topic, I just wanted to pick up on some positive data within the reports. One I noticed was the falls, the reduction in falls, which is very pleasing to see, but also the initiative in non-obstetric ultrasound. And I wondered, Catherine, if the measures that had been taken in that sphere could be replicated in other spheres.
Absolutely. So what we have done in the non-obstetric ultrasound is we've invested in training ultrasonographers. We work to secure funding so that we could actually build capacity and resilience in the workforce going forward. We know that ultrasound is an area that radiographers and indeed other clinical staff can extend their roles into, and we've been very, very successful. We've got really strong leadership in that department. That is a really positive influence for change as well, and they really have taken on and they own their challenges within that department. So there are most definitely opportunities for learning, Boyd, through what that team have done to take that improvement forward. And I should say as well that what the team have done has been recognised nationally across the National Diagnostic Workforce Improvement team, and this team have been asked to go and represent what they've been doing in the national forum, which is really positive for Highland.
Thanks, Catherine. And as David said, we're being asked as boards to take limited assurance on the performance of the system due to the continued challenges faced by the health and care services. And the annual delivery plan and the winter plan will support mitigation efforts where possible. Are we happy to approve that? Thank you. Well, we move on now to item 7, and another area which is always difficult, and that is the area of finance. And ask Hella to speak to the paper.
Thank you, Boyd. I think as we've already touched upon through the performance report, the financial position is challenging, and obviously performance and finance do stand hand in hand. So a lot of these conversations are interlinked, but I will take you through the main highlights of the report, and I will focus more on the movements in forecasts, so some of the things that have driven those changes. At our October position, so the end of month 7, we are at a deficit of 22.548 million, and that's increased our forecast then to 42.981 million, which is unadjusted for some of our recovery actions, which I will talk through later in the paper. As it states, Scottish Government continue to expect our minimum plan position is achieved. So that's our 16.272 that we set out at March at the beginning of the financial year. That's still their position that they are holding us to, and we are working towards delivering that position, but it is becoming increasingly difficult. So some of the main reasons for the movement in the forecast, as you can see from the service positions, our acute services have moved from 20.15 forecast in month 5, which is now sitting at 27.8 million. And the Highland Health and Social Care Partnership has moved from 10.416 forecast to 12.6. With the main reasons for those movements being slippage in our savings targets, which is now sitting at 16.5 million undelivered. And as we've already discussed, that the planned care allocation reduction, so that has impacted our forecast as well, as we've received less allocation that we were expecting. We can also see within the table that shows a breakdown of the operational pressures and the savings element of that as well. So we can see which parts of that is undelivery of the savings and which part is due to operational pressures. In the most part, the Highland Health and Social Care Partnership is predominantly unchanged other than savings slippage, apart from within adult social care, where the forecast has increased from 2.7 million to 4.4. So that's obviously increases within that area, with higher packages being put in place and more pressures within our care home systems. Within the acute services, our main movements are within medical division, which have moved from 6 million forecast to 10 million. Surgical specialties have moved from 3 million to 3.8 million. And then you can see within the senior management and central, that's now increased to 8.8 million. And that does include our savings target for the acute area, but also the planned care under allocation is sit within there as well, just to break down that figure. And Belford Hospital's forecast is increased by 0.6 million as well. And within the acute position, there is a reduction in our forecast spend on drugs. So some of those worsening positions have been offset to some extent by a reduction in our drugs forecast. And that's just been through more accurate reporting and information that we've had. Moving on to our COVID expenditure. Our forecast has increased again from 22 million to 23.4 million. And the information on the IGB and partnership funding, we were told by Scottish Government back in the last report that to expect some of the underspend that we reported at month 6 to be taken back off us. We haven't had an update as to that situation at the moment, so we are assuming that anything that we've not declared as being spent at month 6 will be taken back. But as I say, we haven't had confirmation of that at the moment. Moving on to area 9, which is around the financial risks. These are predominantly unchanged again from the last report. The areas I would draw attention to probably would be agenda for change pay awards. We have had confirmation that the agreed position on the uplift will be funded by Scottish Government, so that won't be an additional pressure financially. However, for us, we do have a slight different nuance with the partnership, where the staffing within the adult social care element isn't included within the agenda for change figure, so there might be some financial pressure from there. Our recovery plan was therefore, so I've mentioned this, recovery plan was submitted back for Q1, and it was a plan of just shy of 20 million, which would have brought at that time our forecast overspend down to 13.6 million. We have now recognised 2 million of that shy of 20 million into our position. So some of that is already in our forecast. And due to the worsening position of our forecast, the best case we will get to, if we do realise all the other recovery actions, which we're still waiting for confirmation on some, would bring our position down to 26 million. So we still have a gap of about 10 million from the position that Scottish Government are expecting from us. There is a breakdown of the recovery plan in Appendix 2, and many of those outstanding actions are technical adjustment actions that we're waiting for confirmation from Scottish Government to fund. And then that finally brings me just onto the capital position. We have spent an element of the capital, but we still are running a fair bit behind our total allocation of 42 million. And we are being assured through the groups that will be spent. The majority of our spend so far to date is on the National Treatment Centre, but we do have relatively high assurance that that full allocation will be committed by the end of the financial year. And there are some other areas already potentially looking for funding as well. So between all of our programmes, we will balance that. As with the performance report, we are suggesting limited assurance from the finances, and this is predominantly due to the level of risk that we're seeing, the financial risk. We still have some outstanding allocations that we haven't received. There are still some unknowns around our pay pressures and inflationary pressures. So the situation is being monitored very carefully. We are looking at areas where we can reduce spend where we can, and we are putting more scrutiny into our planning for next financial year, where hopefully if we start putting some interactions into place now, that they might start to get traction for next year. I will finish at that point and open up to questions.
Thank you, Hela, for the commentary, and invite colleagues now to ask any questions, make any contributions. First up is Gaynor, followed by Susan. Gaynor.
Thank you, Boyd. Thank you, Hela. So obviously we're in a bit of a tricky position, and I just wondered how we're going to work going forward, but thinking more for the medium to longer term into next year and over the next 3 to 5 years, in terms of getting back that ability to realise the savings. And the other main cost seems to be, so the costs are really exacerbated because we haven't achieved our savings for this year, but also they seem to be lots of high costs in relation to staffing going forward. So just how we're thinking of ways to manage that in the shorter to medium term going forward. Thanks.
Thanks, Gaynor. Yes, there are a few actions that we are trying to put in place now. So some of the short-term actions around just having good governance in place and making sure that that's recommunicated to people. I think some of the good practice that we had has possibly slipped during COVID, during the need to spend and react and recover. And we're just trying to get that back in place where managers are aware of what they have authority, I guess, to do again now. So we're strengthening the scheme of delegation, and that will be recommunicated back to the organisation just to make sure that higher level decisions especially are being monitored. And we will be putting the finance recovery, which will probably be a review board, back in place, where we're looking at the entire financial position, not just focusing on savings for each of the areas, so that we're trying to increase the accountability and autonomy at the lower levels as well, so that people do have the ability to spend within their budgets, but within the authority that they have, and that we're holding them to account for that. I guess the balance in between the shorter term and the longer term, we're having conversations around our ADP, what the impacts of the actions of the ADP look like, and which ones of those can we realise the earlier benefits from. So where do we prioritise our focus for next year, and offsetting that obviously against outcomes and performance. So joining the two together, and where will we get best outcomes and best financial outcomes from the actions that we're taking. So that's some of the things that we're doing. So as I say, we kind of focus on 3 areas. So we've got our what some might call grip and control, not my favourite expression, but that's around the financial governance element. So, you know, really holding people tight around the things that they're buying and the need. The second one is around looking at our efficiencies. How can we do what we're doing better? And that's both clinically, operationally around some of our processes and procedures, and just making sure that our areas of spend are as light as we can through procurement actions, all those kind of standard things that we were probably doing in masses pre-COVID, and again maybe slipped a little bit. And then the third one then is the more transformation side. So it's balancing those, and that's the really difficult bit, is getting the balance between how do we focus on the here and now and pulling position in versus the long-term sustainability. And we do need to get that long-term sustainability for our organisation. If we just focus on the here and now, we're going to be in the same position year after year. So we have to do a bit of both, and that's challenging, but we are working through that. And I think we're bringing together an infrastructure that's helping to support some of that, where we make sure that the support that we're wrapping around the services hopefully is enabling them to start looking at those priorities rather than necessarily trying to deliver everything at once.
Susan.
Thank you, Boyd, and thank you, Helen. I'd like to just understand a bit more about the unmet savings that we had anticipated, and is some of that a timing issue? They are things that could be achieved, or are they things that we haven't been able, even though we tried them, they didn't bring about the savings we anticipated? I mean, were there some heroic figures in there that just couldn't be delivered? And understanding, you know, how complex the system is, maybe you know, our constraint of resources just means it isn't going to be possible to deliver things that we could do if we had the people on the ground to do it. So could you just unpack that, you know, unachieved savings a little bit for me? Thank you.
Thanks, Susan. I think it is a balance, a little bit of everything. If I'm completely honest, I think that we didn't have a robust plan at the beginning of the year. So we had a financial gap. We had a target that should be achievable. All other things, you know, relatively stable, but we were coming into the financial year without solid plans that had already started. There's always a lead in time to any new plans. So even starting to get those into place this year probably wouldn't quite have delivered the extent that we needed. But all the additional pressures that we're seeing during the year as well, and the need to recover performance, it just doesn't really allow for an environment of saving and change. As we mentioned with the planned care allocation, you know, one of the areas to be able to deliver the activity was to look at capacity gains and have efficiencies within our capacity. Now there's balance there of being able to provide capacity efficiencies versus financial efficiencies. You can kind of bag one or the other, but you can't deliver both. So that's been some of that. And I think, if I'm honest, I think it was just the lack of robust plans at the start, recurrent. A lot of our actions have been non-recurrent and trying to get things in place. So that's why we're trying to focus now on having those more robust, evidence-based plans in place for next year, and just doing what we can on cost control for this year.
Jerry.
Thank you, Boyd, and thank you, Helen, for the update this morning. I was pleased that you covered the movements from month 5 to month 7, because they were a large part of my question. So my questions that I was going to cover. So I suppose I've really just got one question as it relates probably specifically to this year. Where would you pitch your level of confidence that, and we can only base it on what we know, but we don't know what we don't know, that £43 million potential, is that a best case, a most likely case, an optimistic case for a likely peak of the overspend based on what we know today? If suddenly we get allocations that we're expecting we don't get, that will happen.
Well, if we put all the actions that we mentioned in the recovery plan in place, that would bring us down to just shy, well, around 26. So I think that probably is the realistic position. I think a lot of those will happen. We might get it down a little bit more than that. We're seeing movements in our forecast within adult social care, even though there's a lot of pressures there. We do have a reserve still in place that we could utilise for this year. What that then does is weaken our position, obviously, for future years, and we don't have money to invest in change. So we're trying to deliver change and savings at the same time, which is always challenging. So my best guess, and that's all it is, as you say, that the risks are changing on a daily basis, would be around that 25-26 million position. But we do need to get it down. So the aspiration is still 16.
Alex?
Thanks, but Pam's got a hand up. Do you want to come in there, Pam? Or?
No, I was just going to come in at the end, so that's fine.
Okay, that's fine. Just a quick question, Heather, on the discussion you had, what you said earlier on about giving the staff or putting down the accountability further down the line, and that's good, and allowing people to provide the service within their budget was the aim. And that, again, that's great. But how do we make savings if everybody's actually delivering to their budget? I don't quite follow where the savings are going to come from if we're inviting operational units to operate to their budget, unless we're factoring in the savings within the budget that we give them, in which case that's fine, but that's then putting additional pressure on them themselves, because we're actually asking them to provide a service and do savings at the same time. So I'm a little bit concerned about how we're going to do this, bearing in mind that the winter pressures are coming, and they're not. I don't actually think they're there fully yet, as we've seen in the past. They're coming, and we've only got a lot of supplementary staff. What did you say? Almost 12.6 million of supplementary staffing across all areas. That's probably going to have to go up if we're going to provide the service. That might be a bit of a ramble rather than a question, but I'll leave that with you. Thanks.
Yeah, well, savings targets have already been allocated down at divisional level, so not down to budget level. And that's why I think we're not getting that ownership and engagement in it, and we're struggling to find the plans for this year. For next year, the intention won't be to just allocate a percentage across all budgets. I think the evidence shows that doesn't work. What we need to be doing is aligning our savings plans to the ADP and to the areas of priorities. So we are asking managers to manage within the budgets where they have it, unless it obviously links into one of the ADP priorities, which will then be mapped out, and there'll be an evidence base and activity assumptions around those reductions. So that will be bought into, it will be owned, it will be managed through the programme board and monitored that way, so that the people are clear where the reduction is going to happen. So, but those actions will be delivered through a full team of people, I suppose, putting the capacity behind that. So that's obviously the bit that needs a bit more work and refining of where do we put that focus. But that would be the intention of having very clear savings plans and targets against them, and that's where we would be pulling money out, but people would understand what that money is coming out for and why, and the actions needed to generate it. It won't just be a percentage cut. I'm not sure if that fully answers, but it gives you an idea of the direction we're taking.
Yeah, I think Alex is content with the answer. Anne?
I have a couple of related questions relating to adult social care pressures. I wondered, because it's not apparent, well, it doesn't appear to be the case to me from these figures, but then I'm not an accountant. So I wondered whether we're seeing the same level of pressures in adult social care in the Argyll and Bute partnership as we are in North Highland, and if not, why is that the case? And secondly, we are seeing significant pressures that weren't anticipated at the start of the year. We have more pressures on the horizon in relation to care homes and care at home. So I wondered what our strategy is, what our approach is in terms of discussions with our partners to protect the health budget in the coming year.
Thanks, Anne. I am not as au fait with our Argyll and Bute budgets, so I will defer that question to Fiona, if that's okay, Fiona.
It's absolutely fine. And you gave me just long enough to pull up the finance report that went to the IJB last week, because obviously we present the finance information there across health and social care, whereas the information that you've got from Heledd in relation to this report only relates to, if you like, the health portion of our allocated revenue rather than the whole picture. So we're currently, what we reported to the IJB last week is that our month 6 position is 737,000 overspent. So by a quick calculation, about 500,000 of that will relate to social care pressures, and roughly 250, as you've seen on Heled's information, relates to health. So we are under greater pressure on our social care budgets than we are in our health budgets. However, we are anticipating to be at balance by year end. The greatest level of pressure we're experiencing within our social care budget relates to learning disability, high cost placements. And we are putting a post in Argyll and Bute to help us review all of our high cost packages for people with learning disability through the Change Living Fund that's been made available to each authority area. And we believe that we can make a change to our cost profile within year before we get to the end of the 22-23 finance period, which is why we are articulating a belief that we can come to balance at year end. I probably can't make any comparative comment rather than just give you that snapshot of our position, but hopefully that may be helpful in considering any comparative thoughts that you have within the board.
Thanks, Fiona. And if I can ask Louise to come in, maybe describe some of the work that we're doing with partners around our current position with care homes, care at homes, and some of the work that we've been articulating on where we are and where we need to get to.
Thanks, yes, and as people know, we have been very pressured in the care home sector. We're now getting a feel that this is going to start to be seen more nationally. So we were under the impression that we were sadly a forward runner on this, and I think we are, but we're not alone in the fact that we are losing some care homes and we have others that are under significant pressure that we are having to support, which is some of the financial pressures that we've got at the moment. Similar to how the NHS services run, we've got challenges around locum spend, agency spend, etc., with some care homes running entirely on locum and agency, which is an enormous challenge for the system. And certainly some of the work we've been doing is really trying to very clearly understand and articulate what the picture is around our care homes across the area. So what have we got? What are our particular vulnerabilities? Where is our most needed areas of care for the future? And how do we focus down on our highest priority, which is nursing homes, as opposed to necessarily residential care? Can we shift the balance a bit? Because when we look at the information, we still do have a slightly higher percentage population within care homes than other boards, not all boards, but certainly the boards we've done comparisons with. So we do understand that we have an opportunity to try and shift people's care needs from care homes to perhaps care at home, to perhaps other self-directed support, etc. So we're trying to really understand what we've got and articulate a different picture. And we're working very closely with the Highland Council, with our independent providers to look at what our future needs are, and also look at where we need to make some difficult decisions. We do have some particularly expensive care homes that are difficult to resource from a staffing point of view as well. So some of those very remote and rural care homes that have only got 1 or 2 residents. How do we work differently with those people that we can actually provide a service, but it's maybe a different service and a more sustainable service for the future?
Did you want to come back on that?
So I suppose, you know, obviously I'm aware of some of that work, which is looking to the medium to longer term and is very necessary and valuable. I suppose my concern would be more immediate in relation to the coming year, should the council not be in a position to invest or even be looking to cut back on investment in adult social care. So, you know, my anticipation is that there may be very difficult discussions to be had around the coming year, and it would be useful to, you know, hear a bit more, perhaps, detail about that in the future. But I think it would also be useful if maybe at the next Highland Health and Social Care Committee, we could get a bit more detailed information about the in-year pressures that have arisen. For example, whether they're similar to what Fiona has described in Argyll and Bute, and the efforts that I'm sure are going on to address those, so that we can understand a bit more about the, I think, roughly 4 million overspend that we're anticipating this year. So I think that would be helpful for the next committee. Thanks.
Yeah, thanks. And I think Pam wanted to come in. I saw her hand going up on that one.
Yes, I just wanted to add a bit in terms of sort of process and approach, because yes, we are working tirelessly to try and resolve yet another challenging position that involves people and their care at the end of it. I think if you come back to our integration arrangements and you come back to the scheme, the integration scheme, and how we work together as partners to resolve how we prioritise and how we set budgets, that's the bit that we need to get agreement on the framework, both in Argyll and Bute and in with Highland Council, because the difficulty, just as Fiona described, in terms of the social care pressures, which is known to us all and is known nationally, is that will, of course, have an impact on that integrated budget, which then falls back into the health budget. So again, it's another one of those balancing acts that, you know, as the money has become more limited, becomes a greater dilemma. And of course, the statutory responsibility for adult social care still sits with the council, and therefore the council are a key decision maker in terms of how that budget is set and what investment that they wish to put into that, and how happy or not they are to prioritise across the range of services that are delivered. So we need to look at that process of budget setting. And indeed, I do have a meeting tomorrow, a routine meeting around how we square that away, because the budgets in both organisations are under significant pressure. But that responsibility and that decision making has to have the council at the heart of it, because that's where the statutory responsibility sits. So we must make sure that all of our discussions and all of our agreements and the decision making is fully set out with our council colleagues. And I think as a board, the board needs to understand the implications of that. So tomorrow I'll be looking to try and go back to our framework that's already in place and how we will take that forward. And so that for me is it's not, we've got to do something, and we've got to prioritise, because clearly the costs are only going in one direction. So the implications are about how we balance that, how we make sure those critical services continue to be delivered, as best as they can, but are there other areas that we may have to make choices about? And that needs to be collective and considered independently in the different organisations as well, in my opinion. But we will definitely, I think you're right, the Health and Social Care Committee need to look at in more depth at what's going on in year, and we will give further updates to the board on how that's progressing and any risks associated with it.
Louise, did you want to come in on that point?
Yeah, it was just very much in relation to what Pam was saying about this is about our people and our communities. We are also advocating nationally about the challenges, and so that it isn't just, you know, a locally owned issue. We are trying to advocate for our population and say these are the challenges we have in, so that we've got that dialogue ongoing, as well as looking to what's happening in other areas and other boards, so that we can try and work together on these challenges.
Thanks, Louise. Boyd.
Thanks, Chair. And I guess coming in because I know that we do have clinicians and other professional caregiving staff who tune in to board meetings these days. When we use the word savings, we're talking really about efficiencies, which is the other word that we've also been using. And that's about cost efficiency, cost avoidance and cost reduction. It isn't directly about stopping frontline services, which unfortunately can sometimes be a misinterpretation people make. And I just wanted to make that reassurance that I know that the board that's not its focus, but there will be transformation where services change to more appropriately deliver in a more sustainable way, and that can be financially efficient too in some cases. All boards in Scotland face these same sorts of challenges, so we are not unique, and the challenge to us is to have sustainability within an overall budget that now is £1,000 million. So I would just want to emphasise, as Medical Director, the importance of clinical leadership in helping to meet that challenge. It's clinical staff who understand services and who can best assist with some of the transformational change and give the insights as well as the leadership that's needed to really get us to where we need to get to within what's a complex and challenging national financial environment and NHS environment at this time. Thanks, Chair.
Thanks, Boyd. Pam, did you want to come back in?
Yeah, just again to acknowledge the seriousness with which we are obviously taking the position that we are in, and the to some degree the reinforce the disappointment that after all the work that had been done to get to a good financial position, that we find ourselves in a precarious one again. So I think that needs to be acknowledged. I think, as Boyd said, we are not sitting as an outlier, but it's still really disappointing to be in this position. But again, the point that Boyd makes about the frontline engagement, the clinical engagement in resolving our dilemmas is critical, because that is where decisions are taken and where the money is spent. And so we are really trying to build up an approach that optimises that and allows us to make good decisions. So I suppose the more information and the deeper we understand how our services run, how their performance is, both in quality and in numbers, as well as what the spend and resource against that is, and the more we have good discussions about what the art of the possible is and what the risks are, the better able we are to either support and defend the situation of how services run, or indeed to be able to negotiate for how we prioritise on a national basis. So the deeper we get with this, the more understanding, the further across the organisation we reach out and include people in these discussions, then the better. We've got our strategy, we've got our EDP, we've got our performance framework, we've we've been having quite significant discussions about what we add to that to really get that financial diligence and reshaping discussion happening within the front line, and have some thoughts and ideas that are being shaped up for some very early intervention as we speak. So I think just to make sure that the board understand that as an exec team, you know, we are obviously taking this extremely seriously. We are building it into the work that's been done to date and considering further what else we can do. One, to contain where we're at the moment, and so the agency and locum spend, for instance, has also been looked at nationally by a task force. So we're working in that space with the here and now. But really, what can we do to reprioritise in our ADP, or to ensure that our plans really do speak right through to their affordability and sustainability, and they don't just, you know, stop at this is a good idea. And I was witness to, as were others, we've had a few discussions that clinicians have been involved with, where they've been very quick to tell us, you know, opportunities for change that we should be pursuing, maybe in the longer term, but that could both improve what we do, but also balance our budget. So we need to hear that and work with that. Great resource to get to the right place, but it's not going to be an easy journey, and so I just wanted to kind of make those statements. So I hope that's helpful.
Thank you, Pam. Anything finally from you, Helen?
No, that's it. Thank you.
I think we all acknowledge the bleak situation we are facing, and we have acknowledged it and recognised it by strengthening the Finance and Resources Committee, by adding a member to it, in recognition of the fact that finance is going to be a challenge for some time. And we need to have a 3-year plan in place going forward, and a lot of thought will have to be given to these issues in the next few months. We're being asked to take limited assurance in discussing the report, and I take it that you are happy to, or at least content to take limited assurance on this very difficult situation. Thank you. We have overrun time, and I suggest that we now take a comfort break before we have the next item of winter preparedness, and that we resume at 20 past, if possible, 20 past 11.